1, 2, 3. Test. One, two, three. Test mic. Test mic. Test mic check.
حضرتك عبد الله يا فندم اتفضلي حسيبه اتفضلي.
الانتربريشن تاني موجود اكيد حضرتك.
هو المفروض اللي مكتوبين على السيشن
عشان
كتير.
محدش لسه
انا مش عارفه السيشن بيكون حافظ الدكتور طارق هيجي ولا لا؟
الدكتور المفروض اونلاين. بعتله
2 4
دكتور محمد الطيب الجاي اعتذر ودكتور شاكر الدكتور محمد غني.
طب مين من الشير بيرسون المفروض يبقى موجودين؟ دكتور احمد فياض، دكتور طارق هيبقى اونلاين، دكتور طارق هيبقى اونلاين، دكتور محمد طيب اعتذر. ريهام عبد الغني حضرتك؟ لا انا ياسمين نجا. انت ياسمين نجا. دكتور نجا ازيك حضرتك؟ كويس. اخبار بابا ايه؟ الحمد لله كله تمام. طب احنا الثلاثه بقى شكلنا هنبتدي وخلاص. نبدا ايه؟
الاجنده
اجنده اهي. اجنده هنا معايا، ودي اللي احنا هنبدا بالامير. الامير اهو. هنبتدي الاول. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. هنبدا البري كونجرس. احنا دلوقتي عندنا سيشنز لليونج انفستيجيتورز. المفروض موديريتور وهنا دكتور طارق فياض. هل هو موجود اونلاين دكتور طارق؟ دكتور طارق موجود دلوقتي اونلاين؟ لسه ما دخلش. اوكي هنبتدي. هيبقى عندنا الفيرست سبيكر دكتور امير اسكندر. دكتور امير اسكندر is assistant lecturer of dermatology قصر العيني hospital MD dermatology. سوري دي ساره. زميل مساعد طب الحالات الحرجه مستشفى المطريه التعليمي دكتور امير. اهلا بيك دكتور امير. Dr. Amir will discuss incidence of cardiovascular event after kidney transplantation and their effect on mortality. 10 minutes, Dr. Amir.
Okay. Good morning, I'm Dr. Amir. Thanks for this opportunity from Prof. Dr. Tariq Fayyad. Our study is incidence of cardiovascular event after kidney transplantation and their effect on mortality. The preferred method of renal replacement therapy is currently renal transplantation, as this confer improved survival rate compared to those patients on dialysis, hemodialysis or peritoneal dialysis. Renal transplant recipient remain at increased risk of fatal and non-fatal cardiovascular event compared to the general population. Also rate are lower than those patients on maintenance hemodialysis. Approximately 50% of patients die with functioning transplant, with approximately 50% of these deaths from cardiovascular disease. Conventional cardiovascular risk factors such as diabetes, hypertension, and renal dysfunction, obesity, smoking habits remain a major influence on cardiovascular for renal transplant recipient. Immunosuppression medication exert a deleterious effect on many of these well-recognized contributors to cardiovascular diseases and are not to exacerbate the probability of developing diabetes, graft dysfunction, and hypertension, which can all lead to cardiovascular disease. Non-traditional cardiovascular risk factors such as anemia, duration of prior dialysis, graft function after transplantation, hyperhomocysteine, elevated inflammatory marker, proteinuria, acute rejection episode, post-transplant diabetes, and the toxic effect of the immunosuppression medication and the other drug have been strongly linked to increase the cardiovascular event in renal transplant and should consider alongside those which are classified as conventional. Effective prevention and management of cardiovascular disease in kidney transplant should begin during the pre-transplant period and extend throughout the life of the recipient. The aim of our study is to determine the prevalence or incidence of cardiovascular complication after renal transplantation and its effect on mortality. We conducted a single center retrospective study of all patients who had underwent primary or repeated kidney transplant with a graft from a living donor in Cll Kidney Center in period from 1992 until 2014. Data recorded at the time of transplantation, age and gender, body weight, height, and the body mass index, the primary cause of renal failure, type of dialysis prior to transplant, and the previous, and if any previous transplant. History of smoking, hypertension, hypercholesterolemia, prior diabetes, history of cerebrovascular disease, peripheral vascular disease, intraoperative assessment, including the cold ischemia time and intraoperative complication. Post-operative follow-up of any acute rejection infection, patient smoking status, and the new onset diabetes. Biochemical parameters are collected from week 1 to 2 years. The initial immunosuppressive regimen and the change in treatment, the dosage of immunosuppressive drug are also registered, as use of antihypertensive and the lipid-lowering drug after transplantation. Post-transplant cardiovascular event defined ischemic heart disease as stable angina, acute coronary syndrome, positive stress test, elevated cardiac enzymes, need of invasive coronary intervention, congested heart failure confirmed by complete transthoracic echo, and systolic heart failure is defined as ejection fraction below 45. Arrhythmia is documented by ECG or Holter. Cerebrovascular event as a stroke, transient ischemic attack, and cerebrovascular hemorrhage, peripheral vascular disease. the result of our study. The result will be discussed under the following heading: demographic data of a renal recipient patient regarding age, sex, race, weight, height, body mass index, regarding cardiovascular complication, regarding non-cardiovascular complication, mortality or risk factor. Regarding the demographic data, the mean age was 41, male represent 64%. Regarding the body mass index, 44 were obese, 26 normal, 38 severe obese. The main etiology of renal failure in our participant was hypertension 40%, followed by diabetic nephropathy. The risk factor in renal transplanted patient pre-transplant: 81 had dyslipidemia, 41 had hypertension, 35 had diabetes, 22 were smoker before transplant. Our study shows that 81 had mild left ventricular hypertrophy, 70-80% had history of arrhythmia, history of angina in 45 patients, 35 had congestive heart failure, 13 had history of myocardial infarction, 0.4% had peripheral vascular disease. Regarding the laboratory investigation before transplantation, anemia was found in 50% of patients, with mean hemoglobin around 10, hypercholesterolemia in 43%, HDL below 40 was found in 66%, and the LDL above 100 was 53%. The type of hemodialysis والnumber of transplant. Hemodialysis was done in almost 88%. Median duration of dialysis before transplantation was 8 months, ranging from 2 months to 60 months. In majority here in the study was their first kidney transplant. Cardiovascular complication to recipient patient. Percent had post-operative smoking, 85 had antihypertensive drug with median use of 2 drugs, 81 used statins, 71 used aspirin. Development of left ventricular hypertrophy was happening on 50%, stable angina in 22%, acute coronary syndrome in 2.5%. Cardiovascular complication in recipient post-renal transplantation: congestive heart failure recorded in 24% of patients, arrhythmia in 32%, need for pacemaker was in 5%, need of mechanical ventilation in 6%. Many drugs were used as vasopressor. Factor affecting the incidence of ischemic heart disease. This was statistically significant regarding the age, regarding the male sex, regarding the increase in body mass index, regarding the smoking, regarding of development of left ventricular hypertrophy, regarding the proteinuria. Ischemic heart disease more for old age, more for increased body mass index. Relation of ischemic to sex more in male, more in the smoking group. Regarding the relation of an ischemic heart disease للليبيد بروفايل والهيموجلوبين والجرافت فانكشن كانش في significant statistical significance. Regarding the ischemic heart disease في الستادي found 23% stable have stable angina in 22%, and positive stress test was found in 13%, elevated cardiac enzyme in 2%, and 7% need invasive coronary angiography. We found highly statistical significance difference between patients with ischemic heart disease and who didn't have ischemic as the higher age, more male, smoker, proteinuria, and the development of left ventricular hypertrophy. No statistical significance was found between both groups regarding hypertension and the new onset diabetes. Relation of congestive heart failure to age with sex with obesity. there was a statistical significant difference between the congestive heart failure group and non-congestive heart failure group regarding the higher age, obesity, post-transplant diabetes, smoking, development of hypertrophy, proteinuria. No statistical significant regarding the sex or systemic hypertension. الجراف show congestive heart failure يعني from starting from the moderate obesity incidence increase في severe obese more للديابيتس more في الديابيتك. No statistical significance between congestive heart failure and the congestive heart failure group regarding the lipid profile والhemoglobin والgraft function. Risk of development of left ventricular hypertrophy to the age with sex, with obesity and hypertension. There was high statistically significant regarding the age, obesity, proteinuria, and diabetes as they were higher in left ventricular hypertrophy group. Relation of development of left ventricular hypertrophy للdegree proteinuria يعني the more the proteinuria the more the
دكتور
left
أمير،
ventricular hypertrophy.
احنا اتفقنا على 10 دقائق، فحضرتك ممكن تقول لنا الكونكلوجن؟
Renal transplantation remains the gold standard to improve survival in end-stage renal disease. Cardiovascular disease is the leading cause of mortality in the general population as well as in renal transplant recipient. The risk of cardiovascular event is significantly reduced months after transplantation when compared to those with end-stage on waiting list. Immunosuppressive agent with episodes of graft rejection or post-graft failure renal replacement post-graft failure renal replacement therapy as well as traditional cardiovascular risk such as hypertension والhyperlipidemia والsmoking والobesity والproteinuria والdiabetes add to the transplant recipient cardiovascular risk profile. Thank you.
شكرا جزيلا دكتور أمير.
العفو.
شكرا جزيلا.
now دكتور أحمد داوود. دكتور أحمد موجود؟ شكرا. روان. دكتورة روان. دكتورة روان from Alexandria University. دكتورة روان will speak. Dr. Rowan is a nephrology resident at Alexandria University. She will speak about the outcomes of MMF monotherapy in HLA identical sibling living kidney transplant recipients. اتفضلي دكتورة روان، معانا 10 دقايق لو سمحت.
السلام عليكم. My talk about outcomes of mycophenolate mofetil monotherapy for HLA identical sibling live kidney transplant recipients. Starting with backgrounds, although kidney transplant recipient from HLA identical siblings show excellent graft outcomes and low immunological risk, there is no clear recommendation regarding ideal immunosuppressive regimen and minimization protocols to allow graft rejection, prevention of graft rejection, and avoid drug-related adverse events. One size does not fit all. So individualizing patients' drug therapy is a must to obtain the optimum balance between therapeutic efficacy and adverse events. So our aim is to evaluate feasibility and efficacy of MMF monotherapy plus short course of steroids as the immunosuppressive protocol for kidney transplant recipients from HLA identical sibling without induction therapy. Our methodology. This is a case series for all adults kidney transplant recipient at Al-Muwassaya University Hospital during the last 9 years who tested negative PRA before transplantation and received first kidney transplant from HLA identical sibling. Our immunosuppressive protocol starting with MMF at dose of 2 grams 5 days before transplantation, then a short course of IV methylprednisolone 0.5 gram starting day -1 and day 0 and day 1. Then the patient continue on oral prednisolone at dose of 1 milligram per kg per day, which tapered gradually till complete withdrawal after 3 months. After 1 year, if the patient had no rejection and negative BRA, MMF dose was decreased to 1.5 grams. Follow-up include vital signs examination, routine labs, graft function assessed by serum creatinine and estimated GFR twice weekly during the first month, then weekly during second and third month, then monthly, and Doppler assessment of renal graft weekly during the first month, then monthly. PRA was tested after 6 months of transplantation, and we didn't do a protocol biopsy. Primary outcomes include patient survival, graft survival, and the incidence of biopsy-proven acute rejection. Secondary outcomes were severity and the frequency of drug-related adverse events, infections, hospitalizations, and malignancy. Our results from about 200 patients who underwent live kidney transplantation at Al-Muwasa Hospital, 15 patients met the inclusion criteria. The median follow-up period was 38 months, ranged from 6 to 72. Mean recipient age at time of transplantation was 30 years, and donor was 33. 66% were males. More than 50% of donation were male to female or male to male. The main cause of end-stage renal disease was hypertension. 2 patients had native nephrectomy, and 1 patient had preemptive transplantation. The mean duration of hemodialysis before transplantation was 1 year. To our outcomes, patient survival, we had 2 patients died, 1 from intracerebral hemorrhage after 36 months, and 1 after severe COVID infection after 66 months post-transplant. Regarding graft survival, the death censored graft survival was 100%. No one had delayed graft function. The mean serum creatinine was 1.38 after 6 months and 1.25 after 36 months post-transplantation. This the curve show the mean post-transplant serum creatinine over time. All patients continue follow up till 6 months. الديكريس في العدد ده علشان مش كل البيشنت كملوا كل الفولو اب. Regarding acute rejection, 3 patients developed acute antibody-mediated rejection after 6 months. 1 of them had non-HLA antibody, and 1 had acute rejection after CMV infection. The incidence was 6.5 per 1,000 patient months. All patients managed by steroids for 3 days and shifted to triple therapy of oral steroids and MMF 2 grams and tacrolimus. All 3 patients had stable renal function after treatment change, with serum creatinine stable at 2 for 2 years follow-up, and 1 needed hemodialysis. To compare this data with the incidence of rejection in general kidney transplant recipients, the Australian and the New Zealand dialysis and transplant registry, the incidence of acute rejection in all patients was 21%. This is another paper presenting 108 HLA identical transplant. The incidence of rejection was 46%, and 11% had repeated attacks of rejection. Back to our patients, another 2 patients needed to change the regimen of MMF monotherapy for the sake of pregnancy. One of them continued with normal serum creatinine until now, but another one developed acute rejection after change of MMF. She was managed by steroids and plasma exchange during pregnancy, then shifted to MMF and tacrolimus after delivery. And her serum creatinine was stable at 2.5, but she died after severe COVID infection after 66 months. Regarding secondary outcomes, no drug-related adverse events required change in medication or doses. The most common comorbidity was hypertension. The most complication was UTI. 4 patients had severe COVID infection, and 1 of them died, as we mentioned. Total number of hospitalization was 14. The most common cause was infection and septicemia. The mean hemoglobin was 11. 1 patient developed new onset diabetes after transplantation, and 1 had major abnormalities of lipid profile, and 1 developed malignancy. Our conclusion that MMF monotherapy for the first HLA identical sibling live kidney transplant recipients can be feasible and practical immunosuppressive protocol that offer less drug-related adverse events with good clinical outcomes. Further clinical trials supporting minimization of immunosuppression in low immunological risk kidney transplant recipients are needed. And thank you.
Thank you, Dr. Ron.
دكتورة روان، انت عندك 15 عيان HLA identical، يعني كانوا 6 ماتش، يعني identical twin.
لا مش توين، اخوات.
مش توين، اخوات بس سيبلينج لقيتيهم يعني دي بس الفكرة حلوة حقيقي يعني. شكرا جزيلا.
شكرا دكتور. دلوقتي نقدم الدكتور معتز فتحي، استاذ مساعد internal medicine nephrology في قصر العيني University and pioneer في interventional nephrology. قدم لنا محاضرة عن talk عن ال role of shear wave elastography in assessment of chronic allograft nephropathy radiological pathological correlation analysis.
السلام عليكم ورحمة الله وبركاته. رب اشرح لي صدري ويسر امري واحلل عقدة لساني يفقهوا قولي. It will be a great pleasure to be a part of this first African organ transplantation and shared by our intervention nephrology section of the Cairo University Hospitals in this event. By this novel technique, we are going to present for the first time here in Egypt. Talking about renal biopsy, it's a basic procedure. In the classic nephrology practice, we are doing renal biopsies for diagnosis of the pathological changes for our patients regarding acute events or regarding a chronic allograft nephropathy, where renal fibrosis is estimated by the interstitial fibrosis and tubular atrophy. We are having a long list of work up for renal biopsy, renal imaging, blood pressure, urine culture, coagulation status, to prepare our patient to avoid a long list of complications, as you know, as the kidney is too precious. And to estimate the adequacy of biopsy, it's not too easy to have a 2 cores from a very precious kidney transplant patient to have 6 to 10 glomeruli and 2 arteries to estimate a strong or a good report about what we are having regarding Banff score and so for our patients. Unfortunately, there's a lot of complications regarding renal transplantation. First is panic. The patient is having a very precious organ, his transplanted kidney. He's not going to lose. There's pain, injury, visceral injury, hematuria, hematomas, infections, fistulas within the graft, AV pseudoaneurysm, and unfortunately nephrectomies. It's a balance, and the most lectures I do like to attend is to biopsy or not of the graft, cases to present the case and to do a biopsy or not. There is a balance between what is the reward and the risk of the biopsy of our patients. And this slide is talking about the post-procedural care. What about this patient? Is it going to be an outpatient procedure or an inpatient? What does we need to admit this patient to our hospital or not? And what time of hours our patient will go to his work tomorrow morning or resume his anticoagulation? When to resume his anticoagulation? There's a lot of questions we are asking, we are having from our patients after the biopsy. After the accurate diagnosis and early treatment of chronic allograft nephropathy are important for renal allograft salvage histology. Chronic allograft nephropathy is defined by interstitial fibrosed tubular atrophy, which is further categorized according to Banff score system into 3 grades. And recently there is a percentage which is introduced in our reports, but it's not evidence-based. We are seeing in the reports nowadays is 20% fibrosis, 50% fibrosis. This is not categorized in the evidence-based medicine. Do the intervention nephrology had a module that can replace this biopsy in this allograft nephropathy patients with our conventional ultrasound machines? We are now having a conventional machines and wireless machines. There is a module which is called the elastography. Elastography is emerged a new technique that uses intrinsic tissue properties, the elasticity, which is the capacity to deform and return to the initial shape. When this is applied, this is called strain elastography by pushing the probe toward the kidney. Why this technique is easy to obtain in our nephrology practice? Because the kidney transplant is very near. It's almost subcutaneous. We can push, apart from the liver part, from the liver practice, we cannot push the liver, but we can push our graft. So the strain elastography can be applied. But in this study, we're applying the shear wave type. This is the shear wave type of the elastography to detect the propagation of the waves within the kidney. Whenever this ultrasonic waves is delayed, we can measure it by the kilopascal and obtain the shear wave elastography. So we have 2 main elastography techniques. We have a shear wave elastography, which are used in the liver transplant, grafts, and in the liver cirrhosis and so, and the strain part. We cannot use the strain part in the liver transplantation, can use the strain elastography in our nephrology practice. So in this study, we are going to introduce the supersonic shear wave elastography that has been documented to be strongly correlated with the grade of fibrosis, providing a real-time assessment of the tissue stiffness and asking ourselves a question. Is this module can replace the renal biopsy or not? This is the study, role of shear wave elastography in assessment of chronic allograft nephropathy, a radiological pathological correlation analysis to avoid the invasive and the complicated renal biopsy, which is being held in our daily practice. Our patients were 18 patients included our final analysis. The mean time since renal transplantation, 4 years, from 2 years to 8 years. The mean anteroposterior dimensions was 9.5 plus minus 1.8. The renal parenchymal stiffness was 28.6, and the mean serum creatinine level was 2.6. You know, these are the criteria of the most of our patients are going to visit our nephrology clinics. We are following in the clinics. 10 patients were having mild chronic interstitial fibrosis, and eight patients were moderate to severe. This is the lab. This is the lab. This is ultrasound, and if the percentage, which is not introduced in the BANF as an evidence-based, and the positive, we have found that the EFTA percentage was positively correlated with the mean kidney stiffness with R value of 0.57, P value of 0.013, which refer to the higher stiffness of the renal transplant, the higher the EFTA percentage. I want to say that when you have having a patient with a chronic allograft chronic allograft nephropathy, a GFR less than 30 milliliter per minute, you can send this patient for shear wave elastography to know if this kidney is stiff or not. Is stiff enough? Is not stiff? Soft? We can take a renal biopsy or not? If the increased stiffness we can manage as a chronic kidney disease patient. In our study, there is no significant correlation between recipient patient age or serum creatinine with the mean EFTA percentage or mean kidney stiffness value. R value 0.078 and the P value 0.69. This was strong correlation to predict the moderate to severe fibrosis using the cutoff value is 28.6 to 28.67. Of course, we have a lacking of standardization. This technique is not is a novel technique and not used in the usual nephrology practice or radiological centers or so. So we are putting the standards. We do not have the standards to put on and to measure which is stiff or not. So we are starting a practice, and this is the first number we can estimate. This is a moderate to severe fibrosis. So when you send your patient to a radiological center or so, and they come back with a kilopascal 28.67 or above, so basically you had a fibrosis, moderate to severe fibrosis, or a stiff kidney, and the biopsy is not maybe not indicated. So our results showed that the ultrasound shear wave elastography can be used a non-invasive and easily conducted technique, a routine follow-up of patients with renal transplants with adequate sensitivity and specificity. However, no examination protocol or reference value had yet been established. And thank you.
شكرا دكتور معتز. Great presentation.
بشكرك، فكرة جديدة جدا يعني حقيقي يعني. ولو ان احنا ما عندناش اول مشاكل مع البيوبسي في الترانسبلانت لانها غالبا بتبقى سوبرفيشال وبتبقى قريبه، لكن ممكن طبعا تو اد يعني فور اور براكتس. نيكست ساره. دكتوره ساره عرابي. دكتوره ساره عرابي ام دي ديرماتولوجي، اسيستنت ليكتشر اوف ديرماتولوجي قصر العيني هوسبيتال. دكتوره ساره will discuss case report.
Good morning. I'll discuss a case report regarding post-transplant infections. On behalf of Professor Dr. Sami Asmat, our head of the department, and Professor Dr. Tariq Fayyad, thank you for this opportunity. Our patient is a 38 years old male patient, married with 2 offsprings, hypertensive for 12 years. His original disease was focal segmental glomerulosclerosis, with chronic renal failure and stage renal disease on dialysis for 3 months. He had an a kidney transplantation 2 months ago from a donor 36 years old with the same blood group and 3 matches. Cross-matching by CDC, flow cytometry, and Luminex DSA were all negative. Pre-transplant virology, the CMV IgG antibodies was positive in both the donor and the recipient, while HCV, HBV, HIV, and EBV were all negative. Immunosuppression was anti-thymocyte globulin, tacrolimus, mycophenolate mofetil, and steroids with the conventional doses. The operation was uneventful with adequate dialysis, and the patient was discharged with the normal creatinine. But 1 month after the transplant, he suffered from skin rash. Here's the photos of our patient. He has a generalized skin rash composed of papules, vesicles. Some are clear and some are hemorrhagic. Here we can see on the face, he had a crusted lesion on the scrotum, on the trunk, and on the intragluteal cleft, we can see a large erosion surrounded by small erosions. He also had fever and asthenia. So our differential diagnosis was either disseminated herpes zoster infection because of the crusted lesion on the buttocks, or atypical chickenpox-like lesions together with COVID infection. Because the patient had fever, he was immunosuppressed and had the characteristic vesicles of chickenpox. Varicella zoster virus antibodies, the IgM was positive. And because the patient did not take the prophylaxis against cytomegalovirus, we had to do the PCR. And surprisingly, the CMV PCR was also positive, together with the varicella zoster virus. COVID PCR was negative. So based on the virology, our diagnosis was disseminated zoster infection combined with cytomegaloviral infection. Valacyclovir was started immediately in a dose of 1 gram 3 times daily for 10 days. He had marked improvement of the general condition and skin lesions, apart from the gluteal ulcer, which took a longer time to heal. So we shifted to valganciclovir after the PCR results of CMV. After 2 weeks, the patient had marked improvement of the skin lesions. And also the PCR of CMV shifted to negative after 1 month of treatment. Varicella zoster virus disease is a frequent complication in transplant patients with high risk of dissemination. So vaccination is an important prevention tool. And if the patient has seronegative virology for varicella zoster virus before transplant, he should complete the pre-transplant vaccination profile 4 weeks before starting any immunosuppression. Regarding the cytomegalovirus infection, it has variable clinical histological manifestations. The reports are very infrequent, maybe because they pass unnoticed, self-limited, or misdiagnosed. However, the specific CMV lesions in the skin may present with either oral ulcerations, localized papules nodules, or generalized rash in the form of morbilliform rash, verrucous papules, urticaria, vesiculobullous eruptions. Mainly, the site of cytomegalovirus infection, it affects the perianal perigenital area because when it resides in the GIT in the latent stage, it reinfects the skin around this area upon reactivation. Lesions are usually associated with other infections, especially herpes simplex virus. The CMV cutaneous involvement is dangerous. It may disseminate with high risk of mortality, especially in the immunocompromised patients. Therefore, we should suspect cytomegalovirus infection and start early treatment, especially if the patient is not improving on the regular treatment of varicella zoster or herpes simplex virus treatment. Our conclusion, when we see vesicular skin lesions in a patient post-transplant, we should look for herpes simplex virus or varicella zoster virus. This is a rare manifestation of cytomegalo. However, combination of multiple infections is common. And here we report a combination of herpes zoster and cytomegalovirus infection. Because of the high mortality rate, early detection and early treatment are crucial. Thank you.
Thank you, Dr. Saro. Dr. Amr Shaker. Dr. Amr is an assistant professor of internal medicine and nephrology, Cairo University. Dr. Amr will present a case report. تفضل Dr. Amr.
Good morning. Today we speak about a patient. This patient is known to be a male patient, 39 years old, diabetic, hypertensive since 2018, and he has original disease, adult polycystic kidney disease. Unrelated living renal transplant since 2018, has induction therapy with ETG 100 mg for 3 days. The patient was maintained on tacrolimus 2 mg every 12 hours, mycophenolate sodium 720 mg every 12 hours, and prednisolone 5 mg. And baseline creatinine on discharge was 2.3 mg per deciliter of unknown cause because the patient was not transplanted to me. As the patient came present to the ER with cough, shortness of breath, and fever for 1 week duration. Fever was ranging from 38 to 39 degrees with dry cough. Upon representation to the ER because of the pandemic situation, COVID PCR was done and it was positive, and CT chest showed bilateral ground glass appearance. This was a CT chest on admission. There is multiple bilateral subpleural and pre-bronchial vascular area of ground glass obesity, like inflammatory, considered grade 5 for clinical and laboratory correlation, otherwise normal. Examination on admission, blood pressure was 120/80, heart rate 110, respiratory rate between 6 to 28 per minute, and temperature 38. Saturation on room air was 86%, on non-breathing mask oxygen 92%. Abnormal, the other examination was normal, apart there is a scar of the renal transplant, and there was a bilateral line mass of the polycystic kidney. It was not removed before transplantation. Investigation on admission, the CBC showing there is a lymphopenia, and the EBG showing there is a respiratory alkalosis. The saturation is 86%. The creatinine was 5.4, urea 156, and the tacrolimus level was 9.9. CRP is high, ferritin 1169, the dimer is 0.63, and the procalcitonin was weak positive, and the interleukin 6 was 300. Urine analysis free, ultrasound, abdominal and pelvic ultrasound, there is a polycystic kidney and the transplant kidney of average size and echogenicity, and the renal Doppler, the patent renal artery with receptivity index of 0.7 and patent vein. The patient start methylprednisolone 100 mg every 12 hours, merovinam 500 mg every 12 hours, avrosolide 600 mg IV every 12 hours, and apixaban 2.5 mg twice. Tacrolimus was reduced to be was on 2 mg in the morning and 1 mg in the night, and MMF was stopped. Culture were oil withdrawn, but it is negative. All of the culture was negative. No response was observed after 48 hours regarding fever and hypoxia. The patient was shifted to CPAP mask. Tocilizumab was given 400 mg per day, was given for 2 successive days. We wait for the tocilizumab until the procalcitonin was decreased, and we give the tocilizumab in 269 after 2 days, after 3 days from the admission. There was a procalcitonin was decreased to 0.18, and the CRP was 55. Fever improved on the 5th day, but the patient was still hypoxic on non-breathing mask alternating with the CPAP. The patient started the escalation of the oxygen supply gradually starting from the 7th day till he became on low flow oxygen on the 14th day. Gradual tapering of the steroids till the patient was maintained on prednisolone 30 mg. This was a CT chest after the tocilizumab. Follow-up CT chest compared to the previous, there is a regarding the course of the previously noted central and peripheral ground glass appearance, few subsymmetric mediastinal lymph nodes, otherwise was normal. Then the patient started to complain of severe persistent headache with pain affecting the right eye. MRI brain was done, it was normal. MRA normal. MRV, there is a luminal narrowing along the lateral aspect, otherwise normal. And MRI orbit, there is right frontoethmoidal maxillary sinusitis and edema of the right retroorbital fat. The following day, the patient developed preorbital edema and gradually progressed to swelling of the whole right side of the face. We do CT paranasal sinus, show total obsification of the right sphenoid compartment, obliteration of the right sphenoethmoidal air cells, and mild mucosal thickening of the right maxillary sinuses. no pneumonitis frontal sinusitis, and clear rest of the skin sinus. Otherwise, there is a deviation in the nasal septum, and there is a hypertrophied inferior nasal terpenitis bilaterally associated with mucosal thickening of the nasal cavity. Initial consultation was done in the same day. The patient has orbital cellulitis and facial edema of mucormycosis origin. For systemic antifungal treatment and endoscopic debridement of the affected nasal mucosa was done on the same day. The pathology reporting there is invasive fungal sinusitis mucormycosis. The creatinine was rising to be started again 2.9, 2.7, and the CRB rising to 120, and the TLC was rising to 17.8. The patient did surgical debridement and started amphotericin B liposomal for 21 days. Written consent for high-risk graft failure was taken from the patient. The tacrolimus was stopped. Prednisolone dose was further reduced to 15 milligram, and repeated drainage of the nasal mucosa was done till they become clean. Headache and facial swelling gradually improved. After 14 days of antifungal therapy, while the patient was recovered from mucormycosis, he developed acute onset hypoxia, hemoptysis with fever 39 centigrade. CT chest showing there is a bilateral atypical pulmonary infiltration, change more on the left side, likely fungal infection for clinical correlation. And the left side, mild to moderate pleural effusion, right middle loop cavitary lesion with air fluid level measuring 2.2 for 2.4 centimeter. In 25/6, the hemoglobin was dropped from 8.9 to 10, and we gave a blood transfusion. The CRB was rising again, and the liver enzymes began to rising. Serum galactomannan was done. It was positive. This patient has aspergillosis. Voriconazole was started together with amphotericin B liposomal. Fever subsided after 3 to 4 days. Oxygenation improved after 1 week, and the TLC began to decrease, and CRP began to decrease, and also the creatinine is stable on 3 milligram per deciliter. Follow-up CT chest, there is a regressive course regarding the previous noted dense inflammatory changes, total resolution regarding the previously noted left pleural effusion, total resolution of the right cavitary lesion. Everolimus was started when we have a hope for the kidney. So we start everolimus has an antifungal effect, 0.75 milligram twice per day, and prednisolone increased gradually to 30 milligram. Fluconazole was continued for 6 weeks. After 6 weeks, the inflammatory marker became more or less stable, and aspergillosis serology became also negative. Low-dose tacrolimus was added to the everolimus. After achieving adequate tacrolimus blood level, everolimus was stopped. And finally, after take a consent from take the NET consultation that there is no regain from the mucormycosis again, MMF was introduced, and the patient was discharged on serum creatinine 2.5 milligram per deciliter. Thank you.
شكرا دكتور عمرو، حالة صعبة و multiple complications but you decrease the treatment يعني وده appropriate، والحمد لله ان هو يعني passed كل المشاكل ديت يعني.
Yes, الحمد لله.
الحمد لله ان لسه functioning graft كمان. في حد عنده أسئلة؟ any questions؟ دكتور أحمد داوود جا ولا؟ دكتور أحمد داوود. Ahmed Dawood, lecturer, University, Medicine and Nephrology. He'll be giving a talk about outcomes of different induction therapies in EBO incompatible renal transplant recipients in the tacrolimus era.
Good morning. I would like to present today a study about the outcomes of different induction therapies in EBO incompatible renal transplants. So if we speak historically or in the past, EBO incompatibility was an absolute contraindication for kidney transplantation. Until now, even most of the centers just undergo EBO compatible transplants, and here in Egypt, the Ministry of Health requires that both the donor and the recipient have the same blood group to accept the transplantation. But this is because the risk of acute antibody-mediated rejection is high with EBO incompatible transplants. But the recent trend, actually in many countries, ABO incompatible transplants are becoming more and more popular. Okay, and we can see that, for example, in German centers, almost 1/3 of the almost 1/4 of the transplants are ABO incompatible, and in Japan, it's about 1/3 of the transplants are ABO incompatible transplants. So, what is the reason for the growth? The reason of the growth is that we are always in need of more donors. We need to increase the pool of the donors because there are many patients who stay on the waiting list for many years before they can receive a transplant. Also, on the other hand, with recent immunosuppression and desensitization protocols, the outcomes of ABO incompatible transplants are becoming much more better. So, for example, this was a study that was published in CJSON, and it showed that the 1-year graft survival in ABO compatible transplants is 98%, while in ABO incompatible transplants, it's 96%. So the aim of our study was to assess the outcome of the different induction of immunosuppression protocols in ABO incompatible transplants. We compared the outcome of ATG induction with the outcome of basiliximab induction. We retrospectively reviewed the UNIS database. The UNIS database is a national database in the US. It has data about all renal transplants and other organ transplants that are done in the USA. So we reviewed the UNIS database from 2005 to 2017, and we collected the data about ABO incompatible transplants. And we actually, we excluded the patients who are less than 18 years, patients with organ transplantation other than the kidneys, multiple organ transplantations, patients who were maintained on non-tacrolimus-based immunotherapy, and patients with missing induction therapy at the time of transplantation. And we divided the patients into 2 groups, the group who received ATG induction and the group that received basiliximab induction, and we compared their outcomes as regards graft rejection and graft survival. Okay, so actually we identified 14,415 patients with ABO incompatible renal transplants between 2005 and 2017. And all the patients in our study group were maintained on tacrolimus-based immunosuppression, and we've divided them into 2 groups. We've compared actually the 2 groups. We had about 70 patients who received ATG induction, and 8,844 patients that received basiliximab induction. Both groups were similar. We've compared them as regards the renal function, the BMI, the HLA mismatch, the age, the cold ischemia time, diabetes. The only differences were in steroid withdrawal and the gender of both groups. So when we compared both groups, we found that there is no statistically significant difference as regards the overall acute rejection and the early post-operative acute rejection and the graft survival. We can see that the confidence interval is always crossing 1 and the p-value is always insignificant. So our conclusion was that in patients maintained on tacrolimus, there is no difference in outcomes between ATG induction and basiliximab induction in ABO incompatible kidney transplants. But we have to keep in consideration, of course, that basiliximab is usually given to low-risk patients, while ATG is given to high-risk patients. Thank you.
شكرا دكتور أحمد. We'll now have a mini lecture given by the, Professor Omar Abdulrahman, Professor of Clinical Hematology and Bone Marrow Transplantation from Cairo University, about non-chemo approach to cure blood cancer.
مش دي مش اول واحده.
ودكتور عمر has 20 minutes في الجدول.
افهم
20 minutes صح؟
20 minutes. Bismillah ar-Rahman ar-Rahim. Thank you for inviting me for this conference. First of all, I'd like to thank Dr. Maya Hasaballah for inviting me, and of course, Dr. Gamal Saadi. I'll move a little bit from the kidney, and let's focus now on the bone marrow. Well, the title is the non-chemo approach to cure blood cancer. Of course, when you say that I'm going to cure your blood cancer with no chemo, I think that dreams are coming true. Well, this is the theme that I'm going to talk about. First of all, some introduction about the blood cancer, and then the robust concept of non-chemo approach, the amazing achievements that we did achieve really, and the final crucial issues. First of all, in 2021, there has been an article which is very nice regarding the top 10 medical achievements in cancer research, and 2 of whom were related to blood cancer. The first one is the DNA sequencing test. I would rather say that this is one of the revolutionary concepts in the improvement of treatment of blood cancer. And in fact, what did we do is when your DNA is normal, it's okay. But when there is a mutation of the DNA, be sure that a blood cancer, of course, I'm talking about hematological malignancies, that a blood cancer is going to develop. And in fact, very interesting enough that when you identify certain DNA mutation, be sure that this DNA mutation pertains to a specific tumor. And the second thing that in 2020, the concept of liquid biopsy. What do you mean by liquid biopsy? Actually, in order to diagnose what type of tumor, for example, so there has to be an already formed tumor and then you get the biopsy. But now, with a very simple blood test, if your patient had, for example, a solid tumor or whatsoever, and then received treatment, and you want to follow up the patient. So instead of waiting until the recurrence of the tumor, you can just take a blood sample during follow-up, and you will detect circulating DNA, circulating tumor DNA by, again, next generation sequencing. So if you detect this circulating tumor DNA before the appearance of the tumor, be sure that there's going to be a recurrence. Do you like chemo, ladies and gentlemen? I think if you're on the level of adults, this will be a response. Even if you are a pediatric, I think this is going to be a response again. What's the robust non-chemo concept? It's all about cytogenetics and molecular genetics. And what I'm going to show you, ladies and gentlemen, are the things that we are doing on the ground right now. The chronic myeloid leukemia was the prototype, and because of the discovery of the first targeted therapy in the world, and it is known as imatinib, which is a tyrosine kinase inhibitor. When you inhibit the tyrosine kinase, you stop the CML oncogenesis, and had been called the miracle pill. What happened after the miracle pill had been introduced? Believe it or not, ladies and gentlemen, if this is the non-cancer population, these are the chronic myeloid leukemia cells receiving the TKI, tyrosine kinase inhibitors. It is the same survival. But look at the huge difference with those patients with CML not taking the TKIs. Of course, the difference is quite huge. The amazing achievements, we have lot of achievements, of course, but of course I have to just focus about 2 or 3 of them because it's a huge story. But the achievements were at the level of multiple myeloma, chronic lymphatic leukemia, acute myeloid and acute lymphoblastic leukemia, among others, such as Hodgkin lymphoma, very aggressive types of non-Hodgkin lymphoma, and hairy cell leukemia. So for the multiple myeloma in 2021, if you ask me like 10 or 15 years ago, what's the 5-year overall survival of the catastrophic multiple myeloma? I would rather say no more than 20–25%, by even optimism. But look now at 2021. This is from NIH of the US. They estimated new cases around 35,000. They estimated deaths more than 12,000. So the mortality is about 35.5% only. And I have to say only, because actually, as I told you before, the numbers were very, very scary a decade or so ago. So it was about 40% in 2020. By the way, this difference is not small. In 1 year, the mortality rate decreased by 0.5%. It's not something which is small. So the eventual 5 years overall survival is 55.6%. A dream is coming true. Now, the theme of treating multiple myeloma is as follows. First of all, you have to induce remission in the multiple myeloma. Previously, it was exclusively chemotherapy. Now it is exclusively non-chemo, all by targeted therapy. Maybe more than 95% of the protocols do not have any drop of chemo. Still, the autologous hematopoietic stem cell transplant should be done in first complete remission. Of course, it is still chemo up till now. The good news is the maintenance therapy. The maintenance therapy, without which more than 90% of patients after the transplant are going to relapse. With maintenance therapy, essentially no chemo and even oral treatment. So in a dream that we can turn multiple myeloma into a chronic disease by maintaining the oral maintenance therapy. How? Because we have a hell of a lot of targeted therapies, including proteasome inhibitors, immunomodulators, monoclonal antibodies, among others that I don't have time to say. And all of these are with different mechanism of action and synergistic effect. The second one is chronic lymphatic leukemia. What happened? It's all again about cytogenetics and molecular genetics. So this is the curve on a very long-term follow-up. When you have deletion in your chromosome 17 in a CLL patient, be sure that this is the worst ever prognosis. And fortunately, if you have deletion 13, it's the best prognosis. So this diagram, in fact, ladies and gentlemen, did give us a lot of improvement in the treatment of lymphoproliferative disorders in general, including the chronic lymphatic leukemia. And if you are talking about the B cell receptor at the top of the immunoglobulin, you will find that the BCR signaling, so let's say it is stimulated in the BCR by the tumor. Once you go into this signaling pathway, you will develop oncogenesis. If you break any one of these steps, you will stop oncogenesis. And that's exactly what happened. Beginning from anti-CD20, of course, the very well famous rituximab, but now we have the second generation, which is obinutuzumab. Forget about the drug name. We break this step by a drug called idelalisib, but the proton tyrosine kinase activation is a very potent oncogenic process, and we have two very important drugs known as ibrutinib and acalabrutinib. And believe it or not, in the past like 5 or 6 years, we started to play on the BCL2 family inside the mitochondria. Normally, the BCL2 family is responsible for apoptosis. So when apoptosis loses its control, there will be oncogenesis. So we started to play on the BCL2 by an inhibitor, which is extremely important nowadays, not only in lymphoproliferative, but also even in acute myeloid leukemia, because simply when you produce a drug which retains apoptosis to normal, so it's very, very important. And usually venetoclax works when others fail. Clinically speaking, of course, science is always surprising, ladies and gentlemen. So everything was going just like, quiet. And then all of a sudden you develop a surprise. And really, ladies and gentlemen, this is a surprise. This is the CLL curve. And as you can see, this is 724 patients from the years 2009. After the introduction of the novel agents till 2017, this is the overall survival. And in fact, it is not yet reached. So it is plateauing up till now. And as you can see, the p-value is extremely significant. Well, the final crucial issues, something called MRD and CAR T cell therapy. MRD, minimal residual disease. Please pay attention with this very important thing because really it is a game changer in the field of hematologic malignancies. MRD, or minimal residual disease, it is that part of the tumor cells which are still persistent in the patient, cannot be detected by the usual lab techniques. As I said, it is revolutionary. Why? In fact, with the use of minimal residual disease, two nightmares actually started to be some sort of a good dream. And in fact, if I can dance like this, I would, because they are playing with acute myeloid leukemia and acute lymphoblastic leukemia. With acute myeloid leukemia, look at the very poor results that we have in 2021 at, for example, in the USA. The estimated new cases more than 20,000 and the estimated deaths more than 11,000, so ending into about 56% mortality up till now. So unfortunately, the 5-year overall survival didn't even reach 30%. So indeed, it is very, very frustrating. And that's why, ladies and gentlemen, the main cause or the main point of frustration is you have to answer this question: when to proceed for allogenic bone marrow transplantation in patients with AML. Every 3 or 5 or 4 years, the guidelines change. Transplant at this stage, transplant at this stage. Oh, when the patient with AML is having so and so, transplant. Okay, now there is a unification. In this revolutionary article, there is a novel risk stratification in patients who are undergoing allogenic transplant. Okay, this novel stratification, to your surprise, extremely simple, not costly, and nothing to worry about the cost. It is all depending on 4 points. This one was a retrospective study in more than 1,400 patients. هو ممكن ده يتشال؟ The adverse risk scores were as follows. 1 bad point if your AML is secondary, not primary. Secondary to myelodysplasia, secondary to myeloproliferative, it's always aggressive. 1 bad point for adverse cytogenetics. 2 bad points for MRD, minimal residual disease. If it is positive or unknown at the time of transplant, 2 bad points. And of course, the worst ever is when you transplant your patients with active disease at the time of transplantation, and actually nobody does this because it is terminally offensive. So 4 points to active disease. Let's now see what happened. The scores were as follows. Low score, low risk score, 0 to 2, intermediate 3, high 4, very high 5 to 8. And please look at the result. After analyzing these more than 1,400 patients, it had been shown that from moving from low score to the worst score, you have a 5 years overall survival difference between 8 months to 8 years. So you have to analyze this risk stratification very well in order to achieve these figures. And when I say this, of course, I think it's amazing. I think you will agree with me that it's amazing. So this is the final curve. And as I said, at 14 years, because this is a retrospective study. The other and the final MRD-based nightmare management is the acute lymphoblastic leukemia. In adults, it used to be a nightmare. Still, it's a nightmare, but not that as before. Forget about the complicated figure. All what I want to say is that you give an induction therapy for those patients with ALL, acute lymphoblastic leukemia. Once you reach complete remission, the first question to be asked, what's your MRD status? If the MRD is positive, you can go for a very costly drug as a salvage therapy, which is known as blinatumomab, or consider transplant. If you are MRD negative, you are good. There is no minimal residual disease. So at that time, you can give continue chemotherapy, or you can give a transplant. If you are MRD unavailable, consider transplant. So it's a matter of MRD upon which you will take catastrophic decisions whether to transplant or not. The second crucial issue is the so-called, this is the final part, the CAR T cells. Very briefly, CAR T cells means, in its simplest form, it is a method which has been introduced a few years ago, being applied nowadays, only in very desperate situations with patients with poor prognosis. CAR T means chimeric antigen receptor T cell. So what do we mean by that? It is equals to genetic engineering. So remember the dream of genetic engineering when we used to say in the future everything is going to be cured by genetic engineering. This is genetic engineering. It had been FDA approved in 2017 for the treatment of very aggressive non-Hodgkin lymphoma and acute lymphoblastic leukemia. And it is very promising in hematologic malignancies, but unfortunately not in solid tumors. Of course, it's a very complicated process, but we can simplify it completely. This is actually the cartoon for what do we exactly do for the CAR T cell therapy. First of all, you take the T cells from the patient. The T cells are taken from the patient, and then put the T cells in the kitchen, where you do genetic engineering to engineer those T cells of the patient to attack specifically the tumor. So you engineer, you play with the T cells in order to attack this tumor only. And then ex vivo, you will give lots of growth factors in order to expand the pool of the CAR T cells into billions of CAR T cells. And then you give a very brief chemo, because remember, this is a very aggressive tumor, in order just to subside it, and then infuse the CARs or the CAR T cells in order to crush the tumor. So these are the CARs crushing the tumor. The bottom line and conclusions, this is my favorite bottom line anyway. In conclusion, significant improvement in our fight against cancer. I think the solid oncologists can agree with me that the blood wins versus solid tumors. However, we did not, of course, win the battle yet. And for blood cancer, it is all about cytogenetics and molecular genetics. I'm sorry, if you are dealing with blood cancer and you don't have these tools, please do not treat blood cancer. So the presence is the targeted therapy. The future is cellular therapy and genetic engineering. In hematologic malignancies, I cannot, of course, I can say that we cured, but actually many nightmares may become sweet dreams. But unfortunately, not all sweet dreams end happily, just like this. Okay, it's a happy thing, but it ends unhappily. And thank you very much.
Thank you, Dr. Omar, for this very interesting lecture. وهي برضه cytogenetics are the future of transplantation. برضه دلوقتي البورcine بيعمل لهم البورcine heart and porcine kidney can be genetically modified to be transplanted to humans. So cytogenetics is the future. Thank you very much for this very interesting lecture.
Thank you.
We have
شكرا دكتور عمر.
شكرا.
Any question for دكتور عمر؟ شكرا. كان في جوائز بسيطة للمشاركين. دكتورة روان. تفضلي دكتورة روان. دكتور معتز موجود؟ دكتور معتز؟ دكتور عمرو؟ دكتور عمر؟ دكتور عمر شاكر؟ الله يخليك. اتفضل. الله يخليك. دكتورة سارة عرابي. الدكتور احمد داوود. احمد ايه؟
شكرا.
اتفضل.
شكرا
الله يخليك. شكرا. ثانك يو. شكرا.
والمؤتمر السيشنز النفرولوجي ان شاء الله هتكمل في القاعه الثانيه، يعني هو شغاله دلوقتي اوريدي.
كان في حاجه كان في برضه يعني شهاده للدكتور معتز فتحي، انا ممكن اديها له. انا ممكن اديها له ان انا بقى بتاثر بيا. تمام ماشي شكرا.
ده عمال يا عم يجبر بقاله ساعتين. هروح ازاي؟ اروح بالمركب؟ طب بقول لك في فيديوهات هنا عندك محاضرتين متسجلين. نزلوا لنا كده على طول بقى. المايك ده شغال؟ تحصل مشكلة لما لو شيء من بره ممكن ما اعرفش في اتنين عندك اجانب ممكن يخشوا
اصلا عشان انظر
ممكن يبدأ لو
مم.
هو كده شغال. ميوتد من فوق ولا مش ميوتد؟
فين الفيديو؟
افتح الجمال دي. هو مش فاتحين الكاميرا.
اوكي.
لكن لو كلمتهم هيردوا.
دكتور خوان. Dr. Kwan.
Hi, good morning.
Good morning, Dr. Kwan. We are very sorry for the delay because we have a very bad weather in Cairo with heavy rains and heavy traffics. We will start in just in a few minutes.
No problem. Are
Okay.
you going? Sorry,
but
are
your
you?
lecture, the lecture which is recorded and sent yesterday or a few days, we discovered that it's just 2 to 3 minutes. So is there any problem in the link you sent?
No, I don't think so. I think it's fine. So do you want to use the recording, right?
We are trying to use it as a recorded one, but if it is available for you to present it lively, it will be good.
Oh yeah, I can do it.
Okay. Just 2 to 3 minutes. We will start soon. Okay. And sorry again.
Don't worry.
Doctor, can you try sharing your screen?
Yes, give me just 1 second.
Good morning. We are very sorry for the delay because of the very bad weather in Egypt and Cairo, and very heavy rains and very crowded traffics. And we are very sorry for the dear international speakers. Shall I introduce my chairpersons for this session? We have here Dr. Mohammed Abulaz, Professor of Hepatogastroenterology and consultant of liver transplantation, Theodore Belhart's Institute. He's a dear friend and one of the experts. And Dr. Mona Al-Amir, the Professor of Internal Medicine and Hepatology, consultant of liver transplantation, and she's my colleague since more than 16 years in the liver transplantation unit, Cairo University. She just 2 minutes and she will be present with us soon. I have the pleasure and the honor to present Dr. Juan Pablo. He's an assistant professor of medicine at the Pontifical Catholic University of Chile, trained at the Pontifical Catholic University of Chile and at the Mayo Clinic in the United States. He's a gastroenterologist and hepatologist and the transplant hepatologist. He is a physician scientist with an interest in clinical and translational research in alcohol-related liver disease and non-alcoholic fatty liver disease. He is a director for the adult liver transplantation for the living donor liver transplantation at his institute, and he is currently editor of the hepatology highlights section of the hepatology journal, and the secretary of ASLD Special Interest Group in Alcohol-Associated Liver Disease, vice chair of the ASLD Global Outreach Subcommittee. Welcome, Dr. Juan. It's the first time to see you, and you're welcome.
Thank you very much. I would like to thank the African Society of Organ Transplantation for inviting me to discuss. Today, we are going to talk about liver transplantation waitlist survival optimization. What should we do? I'm Juan Pablo Arad, and I was already presented. So I have no disclosures. So the aim for this talk will be to discuss recipient optimization, mainly trying to focus on frailty, sarcopenia, nutrition, and immunization, to discuss a special group, such as those patients with ACLF and some disparities on prioritization, and to briefly discuss about how we can expand the donor pool. When you have a patient on the liver transplant waitlist, you can improve survival by, number one, optimization of the recipient. This is basically frailty, sarcopenia, nutrition, or immunization. Number two, expanding the donor pool. And here you have some options, such as DCD, living donor liver transplantation, machine perfusion systems. Or number three, selecting correctly the special groups. And I'm going to touch these topics. So the first topic is recipients optimization. One of the most important things that we have learned over the last years is about frailty and sarcopenia. So in addition to treat the underlying disease, ascites, hepatic encephalopathy, etc., we can target sarcopenia. How do we define sarcopenia? Sarcopenia consists in the loss of muscle mass as well as muscle function and performance. Obviously, this concept is broader than cirrhosis alone, and much of the data are from non-cirrhotic patients. Research of sarcopenia and cirrhosis has been focused on muscle mass, mainly through cross-sectional imaging with an heterogeneity in the choice of measure and cutoff. So in regard to measures, various authors have used psoas muscle thickness, paraspinal muscle index, or the total skeletal muscle index at L3. There are several key determinants of muscle mass and strength. A major one is sex. Men have more muscle mass than women. Ethnicity is another one. African American will have more muscle down, going down to Asians. And age, after the age of 50, our muscle will start losing mass at a rate of 1% per year. Muscle strength related to the decreased muscle quality due to the fatty infiltration and conversion of muscle fibers from type 2 to type 1. And how is it compared to muscle mass data in cirrhosis? This is retrospective data, so limited in its interpretation. But looking at this, we can see that patients with cirrhosis lose muscle mass more quickly, even up to 6% per year in Child-Pugh-C patients. How do we define frailty? And again, this is not only exclusive for cirrhosis. From a global perspective, frailty is defined as a clinical state of decreased physiological reserve and increased vulnerability to health stressors. Looking at the graph, you can see how a robust cirrhotic patient can have a decompensation, decreasing his functional capacity, but then bouncing back. If the patient is frail, will not have the capacity of bouncing back after a decompensation and will go to a state of disability in cirrhosis. In cirrhosis, it has been more studied the physical component more than the multi-model component that is currently ongoing. The pathophysiology is multifactorial, and still more research is needed in this. Sarcopenia is the result of the protein imbalance between protein synthesis and degradation. This is affected by inflammation, bacterial translocation, reduced dietary intake, significant reduction in physical activity, reduction in glycogen storage, so they mobilize muscle to produce energy, and of course, ammonia and testosterone. How do we measure these concepts? Probably the most common evaluated is the liver frailty index, but also the 6-minute walk test and the gait speed. And to assess sarcopenia, CT for cross-sectional images of muscle mass, which has some limitation as we discussed. So other options have been developed, such as the thigh ultrasound, the bioimpedanciometry, or the face angle. So basically, the tool that you pick will depend on the purpose, setting, expertise, and access of your team. This study from more than 35,000 adults showed that how muscle functions correlate with survival. Here, gait speed was used to predict life expectancy. So all these predictors can be used in cirrhosis. Here you can clearly see how sarcopenia predicts survival in cirrhosis independent of MELD score. Similarly, this study by Dr. Jennifer Lai showed that compared with MELD sodium alone, MELD sodium frailty index, including hand grip strength, balance testing, and chair stand, which all this takes less than 5 minutes to do, better predict survival, adding up to 9 points to the MELD score. In this study from my university, frailty was independently associated with decreased survival at long-term follow-up. Reduced gait speed was strongly associated with mortality, and it could be a surrogate marker of frailty in the clinical practice. So we can aim to improve sarcopenia by nutrition and exercise. First, with nutrition. This paper by Dr. Tandon from Canada gave us the prescription. The first choice would be use of indirect calorimetry. However, we can use predictive equations, which for non-obese patients would be at least 35 kilocalories per kilogram per day. Protein will be for 1.2 to 1.5 grams per kilogram per day, using late night snacks, and try to use branched chain amino acids, especially on those patients who are protein intolerant or unable to meet protein targets. This randomized controlled trial from India showed that nutritional intervention improved minimal hepatic encephalopathy at 6 months. This was 71 versus 23% compared to controls. Also had significant improvements in quality of life, muscle mass, strength, and reduced hospitalization. This is only one randomized controlled trial, but their findings are very interesting and will be interesting to replicate them. The next step in management is exercise. Exercise increases physical performance, quality of life, muscle strength, muscle size, and reduced portal pressure in patients with cirrhosis. Some liver transplant centers have implemented formal rehabilitation programs. So the recommendation is resistance training at least 2 days per week, and then aerobic activity 3 to 5 days per week, aiming to target at least 150 minutes of moderate activity per week. Obviously, in those patients that are very deconditioned, working with a physical therapy is best, starting from a slow and then increasing in intensity. This point is very important. In this study from New England Journal of Medicine, when calories are restricted, 75% of weight loss is fat, but 25% is muscle. So always prescribe exercise if you are prescribing weight loss, and combining aerobic and resistance exercise with diet seems to be the most effective in improving physical performance. And what about pharmacological therapy? Nothing really ready for the prime time, but testosterone has randomized controlled trial that demonstrated benefit in increasing lean mass, bone mass, and reducing fat mass. However, no impact on muscle function or quality of life. The big question then is whether prehabilitation or pharmacotherapy aiming sarcopenia may improve outcome post-liver transplantation. There are few ongoing trials on this, and we should be able to have more information in the near future. Another important topic is vaccinations for cirrhotics, especially in those times of COVID. There are immunization recommended for the patient with chronic liver disease by the CDC. There is still research to be done regarding the efficacy and the best timing for these vaccines in the liver transplant setting, but generally, these are those who are already recommended. And what about COVID? And this is topical during the pandemic. This study from Germany analyzed the response to COVID vaccine among patients with cirrhosis and liver transplant recipients. They found that after the second dose of vaccination, seroconversion was achieved in 63% of liver transplant recipients and 100% of cirrhotic patients and controls. Furthermore, spike-specific T-cell response rates were 37% for liver transplant, 37% for liver transplant recipients, 65% for cirrhotics, and 100% for controls. Altogether, 28% of liver transplant recipients did neither develop a humoral nor a T-cell response after second vaccination. So this data supports a third dose for those patients. The other big topic is how do we address disparities or consider special groups in organ allocation or prioritization for liver transplantation. The first group is patients with ACLF. Although this is matter of debate, patients with ACLF have increased mortality, so we need to somehow acknowledge it. In this study from 2019, using data from the UNUS registry, they compare liver waitlist mortality or removal according to MELD score versus ACLF category. They found that patients with ACLF grade 3 were more likely to die or even be removed from the waitlist regardless of MELD sodium score compared to those ACLF with other ACLF groups. The proportion was greatest for those patients with ACLF3 score and MELD sodium score below 25. So certainly, patients with ACLF grade 3 have poor outcomes regardless of MELD score, even having low MELD score. Liver transplantation increased odds of survival for these patients, particularly if performed within 30 days of placement on the waitlist. Mechanical ventilation at liver transplantation and the use of marginal organs were associated with increased risk of death. More recently, this study showed that among candidates listed for liver transplantation with ACLF at listing, MELD score and ACLF interact in predicting cumulative risks of 90-day with waitlist mortality. The impact of ACLF grade on 90-day waitlist mortality is much higher at lower listing MELD score, especially below 25, the same that was shown by the previous study. The author proposed a novel score using MELD score and ACLF grade in listing, providing a most accurate estimate of 90-day waitlist mortality. So in summary, this data showed that patients with relative low MELD scores, meaning less than 25, had high mortality rates regarding ranging between 30 to 40% if they are ACLF grade 2 or 3. It will need to be discussed whether these patients would get some prioritization with certain criteria, but again, this is a matter of debate. Just few words regarding other special groups. Recently, it was published the MELD 3.0 score, which number 1 was updated with contemporary data. Number 2, the creatinine was maxing out at 3 milligrams per deciliter. And number 3, female sex and low albumin was adding to the score. So this score was intended to reduce disparities and prioritization of certain groups. And finally, expanding the donor pool. Obviously, we will need to increase the number of donors if we are increasing the number of recipients to reduce the waitlist mortality. I won't spend too much time on this, but One option is maximizing deceased donors through number 1, deceased donor after cardiac death, number 2, split livers, number 3, using marginal livers, or number 4, using machine perfusion systems. Another option is increasing donor pool through living donor liver donation. And here I want to spend a couple of minutes. For example, in Chile, we were able to reduce almost by half waitlist mortality after the introduction of a living donor liver transplant program. And I thank Dr. Martin Deep for sharing this data. This can be very good alternative in countries with low donation rates. And this is very important because, as you can see here in the graph, the survival with living donor, if you consider the time from the wait listing, is even better than the deceased donor. And maybe in the future, we are going to have artificial liver to increase the liver donor pool. We recently have news from a cardiac transplant using a modified pig heart. So probably in the future, we are going to have new technologies for the liver. In summary, frailty and sarcopenia are common in patients with cirrhosis and impact waitlist mortality, and it will be key to assess whether sarcopenia management, especially prehabilitation, improves post-liver transplant outcomes. Nutrition, exercise, immunization, and the identification of high-risk mortality groups are likely to improve waitlist mortality, and strategies to increase the donor pool are key to tailor strategies to local donation rates and culture. Once again, I want to thank you for inviting me to discuss about this topic, and I will be happy to take questions. Thank you.
Thank you, Dr. Juan, for your excellent presentation. And if you allow me just a few questions. First one, when do you say no for a liver transplant candidate as regard frailty? Do you exclude patient from transplantation because of severe frailty?
Well, that's a good question. At this point in my university, we very rarely exclude a patient only because of frailty. In other place, I know that if they have a 6-minute walk less than 200 or 220 meters, they will exclude them. In my program, what we are doing at this point is including every patient in a prehabilitation program. If they are not able to undergo the prehabilitation program, probably they will be excluded. But in my experience, it's very unusual to exclude a patient only because of frailty. We are very aggressive with the exercise, with the prehabilitation program, using physical therapies and also nutrition. If the patient is not able to feed himself, what we will do is using a nasogastric tube and give some night feeding, tube feeding.
Thank you, Professor Juan, for your comprehensive and elegant talk. Actually, my question, how could you convince the patient with liver cirrhosis, especially on the waiting list for transplantation, to perform exercise regularly 2 to 4 times a week or so? He's generally weak, as we all know. How could you convince? Is it applicable actually, or it's theoretical?
Yeah, it's not easy, and probably you need to, number one, involve the patient, and number two, involve the family. Since our prehabilitation program is included in our liver transplant program, basically it's covered, so the patient doesn't need to pay for it. The patient is more willing to do it, and probably also depends on how you explain this to the patient. And what we do is we say this is a requirement for liver transplantation, for wait listing. So basically, we say the patient that he needs to undergo the rehabilitation program. It's part of the evaluation for listing. So yeah, we need to push a little the patients to really work on physical therapy and nutrition. We need to make them realize that this is as important as all other evaluations.
As regards the caloric intake and the protein as you said, and according to the EASL guidelines, 35 kilocalorie per kg per day, and the proteins 1.5 gram per kg per day. What is the kind of proteins to avoid precipitating hepatic encephalopathy?
Yeah, that's a great question, and it's usually a common problem. What I would say to my patient is the most important thing is reaching the protein goals. If they are developing more hepatic encephalopathy, what I do is treating the hepatic encephalopathy. I never condition the amount of protein for the hepatic encephalopathy, and probably I will increase treatment, more lactulose or rifaximin or whatever is available. What I found very useful are the brain chain amino acids. It's not that easy to be found, but they not only help with the protein intake and meeting the protein goals, but also there is some evidence that they will help with the hepatic encephalopathy. So every time I can, I will prescribe BCAA, the brain chain amino acids. And the other thing is protein snacks at night. So basically, here we have even yogurts which have 10 grams of protein. So I recommend or a protein bar or a high protein content yogurt to be taken as a late night snack. Yeah, that's the way that we do in most patients. However, there are some patients who are too malnourished that they will need nocturnal tube feeding. So basically, they will not meet the goals during the day, but then we make sure that they at night they will receive at least 1,000 calories and 60 grams or 50 grams of protein. So when they are sleeping, we are having the baseline protein goal and caloric intake that we need, and then whatever they drink and eat during the day will be on top of that.
Yeah, thank you. As regards my last question, as regards the sarcopenia, what is the best method? As we all know, there is the psoas muscle thickness, and also more recently the skeletal muscle, abdominal muscle at the level of L3 vertebra. What do you prefer?
I think,
center?
Yeah, I think there is no standard method or best method. It will depend on what do you have available at your unit and what your team is used to use. In my hospital, most patients will have a cross-sectional imaging, so we will have a CT scan. So we are using psoas muscle mass, but also we are now moving to using more dynamic and bedside things such as the bioimpedantiometry. And also there is very interesting data from Canada, from Dr. Tandon from Alberta, that she was using thigh ultrasound. I think ultrasound is also interesting because can be used bedside, is cheaper, and you can follow these patients.
Thigh ultrasound.
Thigh ultrasound, yes. And the other thing that I think is useful is combining methods. For example, I use hand grip strength, combine it with any other method to follow these patients. This is more than the cross-sectional picture that you have at one time point. I think it's best when you follow this patient and you have multiple measures over time, so you can see if the patient is improving or not. And this is very evident for me. I have a hand grip dynamometer, an electronic dynamometer that I bought in Amazon for $20. And I do it for all my patients in the post-transplant clinic. And you can see how weekly they improve the hand grip strength. So this is a very fine way to assess sarcopenia and how they are improving. Or even if you use it pre-transplant, you can see how they are worsening with the worsening of liver disease.
Okay, thank you very much.
Welcome.
Thank you, Professor Juan, for this elegant lecture. Thank you very much. I'm Dr. Mohammed Abulaz. I'd like to ask you a question regarding the frailty and sarcopenia. In such patients, when we decide that this patient is actually having a marked frailty, is there, in Egypt here, we transplant the liver donor liver transplants, and that's my question here is there a graft weight ratio threshold that we shouldn't go under in these patients? And in another form of question, is there a better graft weight ratio that could reach a better success in these patients?
Yeah, that's a great question, and I think there is no a correct answer to as far as I know. Usually we never go below 0.7. And I will say if you go over 0.8, you will be in the safe side. But there is no studies assessing this as far as I know. And probably Dr. Sessner, she has a vast experience in living donor liver transplantation more than me. So probably when she is her time for question, we can came back to this, but I will say never go below 0.7 and ideally over 0.8 just to be in the safe side. Usually when patients are very deconditioned and malnourished and sarcopenic, we will defer the living donor liver transplantation as much as we can to improve the nutrition status, because when different with a deceased donor, we can plan, but with living donor liver transplant, we can defer a couple of weeks or even a month or two if the patient is able to wait to improve the nutritional status. So it's not a common problem for us, but yeah, it's a great question.
I mean, logically, if we increase the graft weight, it's going to be a better sequelae, yes?
Exactly.
Another question, please. So if we were stuck and we've got to transplant such a patient, and we did, is there any post-operative measures that we can support the patient in order to get a better survival in the short post-operative period?
Yeah, the main issues for us is, the problems after liver transplant will be the same problem that we were having just before transplant. So the main thing will be still nutrition. So we need to be very aggressive with nutrition and with physical therapy. We basically start working with physical therapy the day after the liver transplantation. And we try to make this patient walk around as soon as possible. And the other things are infections. What we have seen at these patients are prone to develop every kind of infection, especially pulmonary infection due to long time on mechanical ventilation. And so I would say be mindful of infection, actively look for infection, treat them, and then work on nutrition and physical therapy as soon as possible.
Okay, thank you very much. Thank you.
You're welcome.
Thank you again. Because we are short of time, we have to move to the next presentation, Early Graft Dysfunction, a Dilemma to be Solved, by Professor Nazia Selzner. She's a transplant hepatologist in the multi-organ transplant program, University Health Network, and Associate Professor of Medicine at the University of Toronto. Professor Nazia is a scientist at the Institute for Medical Science as well as at the Toronto General Research Institute.
Good morning, everyone. Greetings from Toronto, Canada. First of all, I would like to thank the organizing committee, particularly Professor Syed and Professor Saadi for their kind invitation to this first ASOT Congress. It's my pleasure to discuss with you on the topic of early allograft dysfunction, a dilemma to be solved with you all. I have no conflict of interest for this presentation. During this presentation, I will review with you the definition of early allograft dysfunction as is applied to the deceased donor liver transplantation versus live donor liver transplant. We will review the impact of this entity on the outcome of graft and patient survival. We will talk about the predictors of early allograft dysfunction and some of the approach to treatment at the very end. So first of all, before we dive into further into early allograft dysfunction, a few words in terms of the terminology and the definition. As you all know, early allograft dysfunction is very different in the setting of deceased donor liver transplantation, where ischemic injury to a graft, some of the donor's risk factors, the length of cold ischemic time or the length of warm ischemic time in the setting of DCD liver transplantation could cause this non-functioning of a full graft, either with a primary non-function or a delay allograft dysfunction or early allograft dysfunction. While in contrast, in the setting of living donor liver transplantation, none of these risk factor really exists. Ischemic injury does not exist. The donor are excellent, good health. The quality of the graft is excellent. The cold ischemic time short. And in fact, what causes struggle for this graft in some instances is related to the fact that a graft that is not full size has to deal with the metabolic demands of a human body while facing the regeneration capacity, and this result again in some instances in development of small for size or early allograft dysfunction. So the definition of early allograft dysfunction goes back to the beginning of the transplantation in the 90s and was subsequently validated by Kim Althoff in a multi-center studies. Definition is written here: one or more of the following: bilirubin of higher than 10 milligram per deciliter on post-operative day 7, and INR of 1.6 or higher on post-operative day 7, and a peak serum of AST and ALT or ALT at 2000 international unit within the first 7 days meets the criteria of that graft for early allograft dysfunction. And the incidence of this entity is reported to be around 25%. And most importantly, more than the incidence, what is important to know is that this early allograft dysfunction is associated with a higher risk of mortality and graft loss, as high as 10 times higher mortality in the study by Dr. Althoff in the group with early allograft dysfunction versus non-early allograft dysfunction, and similarly a 7 times higher rate of graft loss. We looked at our own data in Toronto a couple of years ago, and particularly trying to differentiate between the DCD graft and NDD in order to see whether the graft type matter or the donor type matter. We included over 1,000 adult liver transplant recipients in this study from 2000 to 2017, and majority of the recipients were the NDD group. we found an overall rate of 44% of early allograft dysfunction based on Althoff criteria, and with 70% in the DCD group versus 40% in the NDD group. When we looked at patient and graft survival, we noticed that overall recipient who developed early allograft dysfunction showed a significantly lower rate of graft survival, as well as patient survival at 1, 3, and 5 years compared to those who did not have any evidence of early allograft dysfunction. This difference existed when we separate the DBD or NDD group from the DCD group. In the setting of the NDD, those who had early allograft dysfunction, definitively patient and graft survival was significantly lower compared to those who had evidence of early allograft dysfunction. But for recipient of the DCD graft, patient and graft survival did not seem to be affected by the presence of early allograft dysfunction in our study. When we looked at the risk factors for early allograft dysfunction for the recipient of the DBD grafts, donor age, recipient age, recipient BMI, and HCV positivity were found to be associated with early allograft dysfunction, with HCV positivity and age being in fact protective, being associated with decreased risk of allograft dysfunction. For the DCD group, in contrast, the only parameter that was associated with risk of early allograft dysfunction was donor BMI, and no recipient factor was identified. Patient who received a DCD graft had a 3.5 times higher risk of developing early allograft dysfunction compared to the NDD graft in our group. To better understand which of the criteria that was proposed by Althoff, which of those has the most influence for the early allograft dysfunction, we decided to analyze each of these three criteria separately. When early allograft dysfunction was defined only based on the AST criteria, we did not find any difference in graft and patient survival, whether when early allograft dysfunction, when the AST was present. However, when the bilirubin or INR criteria were used to define early allograft dysfunction, they were associated with significantly lower rate of graft and patient survival in those with early allograft dysfunction who meet this criteria. Now switching gear and talking a little bit about the live donor liver transplantation. As I explained earlier, in the living donor liver transplantation, a portion of the graft of a donor is removed from the donor and is transplanted in the recipient, and this non-full-size graft has to meet both the metabolic demands of the human body while going through the process of regeneration, and in some instances that results in the struggle with development of small for size or early allograft dysfunction again. In the situation of living donor liver transplantation, small for size syndrome is associated mainly with grafts that have a graft recipient body weight ratio below 0.8 or less than 40% of standard liver volume. And in contrast to the early allograft dysfunction in the setting of disease donor liver transplantation, small for size syndrome is complicated by sign of portal hypertension, particularly encephalopathy and persistent ascites. And the pathophysiology behind it seems to be, is reported to be related to the degree of portal hyperperfusion causing sinusoidal shear stress, endothelial and hepatocytes injury, and finally delayed graft function and regeneration. And from a biochemical parameters standpoint, again, this entity is defined by a total bilirubin above 10 and a INR higher than 1.6, as well as a clinical sign of encephalopathy or persistent ascites. So a few years ago, the A2AL, which is a consortium of North American live donor liver transplant centers, came together and looked at the pattern of early allograft dysfunction in their study. They have looked at 631 adult live donor liver transplant recipients. The definition they used for early allograft dysfunction was the same: bilirubin equal or above 10, INR equal or above 1.6 at postoperative day 7, and they found an incidence of 16% in the first era of A2AL and 19% in the with the A2AL 2. When they looked at graft and patient survival using Kaplan-Meier analysis, they show again a significantly lower rate of both graft and patient survival among those who had evidence of early allograft dysfunction compared to those without early allograft dysfunction. They went on then to stratify the group into two groups: those who had a smaller size of the graft, below 0.8, compared to those who had a bigger size of the graft. And interestingly enough, they show that even those who had received grafts above 0.8, in a subgroup of them, in about 23% of those cases, they found in evidence of early graft failure, which they define as a graft failure within 90 days, compared to 27% of the group of the recipient with weight ratio below 0.8. In terms of the predictors of early allograft dysfunction in their logistic model, they noticed that a left lobe or a left segment graft were much more likely to meet the definition of early allograft dysfunction on postoperative day 7, and also some other parameters such as preoperative bilirubin, donor BMI, and lower alanine aminotransferases were significantly associated with increased risk of early allograft dysfunction. In this study, from Japan, the authors were aimed to validate the early allograft definition as a predictor of the graft survivor for living donor liver transplantation. They included 276 adult live donor liver transplant recipients from Kyoto, and they found that 32% of these recipients meet the criteria of early allograft dysfunction as defined by Althoff, and 22% among them met the criteria for bilirubin, while 17% of them met the criteria of INR. Then they looked at graft survivor after living donor liver transplantation based on the criteria of total bilirubin and total bilirubin and or INR. they found a significant difference in graft survival between the group, with the group that meet both bilirubin and INR criteria having a significantly lower graft survival compared to either those criteria alone or none of the above criteria, and with a relative risk of 6.97 times higher risk of graft loss at 90 days post transplant when the patient meeting both criteria compared to 2.95 relative risk when meeting only PT-INR criteria, or 1.28 if they met only the total bilirubin criteria. Basically, this study was showing that that having an association of this total bilirubin and INR is a useful tool for predicting early allograft loss after live donor liver transplantation. They went on afterwards and compare their 260 patients in this study with 297 patients with deceased donor liver transplantation in the ALTOF study, and they have shown that very interesting that only 4 of their patients, or 0.4% of all the patients, showed the ALT AST criteria greater than 2000 international unit within the first week in their study, as opposed to 8.8% patient who meet the AST-ALT criteria in the deceased donor liver transplantation. And the early detection of AST-ALT levels usually reflects generally hepatocellular damage, mainly secondary to the perfusion injury after cold ischemia, and is based on this does not seem to be a meaningful prognostic factor for a live donor liver transplantation. Most recently, a study from India has tried to compare the diagnosis accuracy of existing definition of early allograft dysfunction and to try to identify other predictors for early allograft loss and formulate potentially a new definition. For this, they applied the existing commonly used criteria definition of early allograft dysfunction to their own population of 304 living donor liver transplantation. They have utilized for this the ALTOF study, the A2AL study group, the Okamura's study, and another study from Japan. And what they were able to show on this table is that none of those criteria performed, all of these criteria basically performed poorly with respect to positive predictive value ranging from 17% to 21% in ALTOF, A2AL, and Okamura study, whereas the definition of Okamura and Igamagi showed a very low sensitivity of 26 and 21% respectively for predicting early allograft dysfunction related mortality. What they proposed in their own study was a new model for early allograft dysfunction in the setting of living donor liver transplantation, arguing that the graft dysfunction in this setting is usually evolve after the first postoperative week, when the regenerating partial graft failed to meet the metabolic demand of the recipient, and therefore they concentrate on the chronological changes that occur in the lab setting, in the laboratory parameters after postoperative day 7. And because early allograft dysfunction is a dynamic process, they looked at every single day for 5 subsequent consecutive days after day 7, and based on that they were able to come with a bilirubin and INR measured daily after for 5 days after day 7. They looked at urea, interestingly, and they found that is increasing their the strength of their model, and they demonstrate finally that a new model of definition, which include a total bilirubin and INR, similar to the previous definition, in addition to a serum urea of above 100 milligram per deciliter, has the capacity to perform better than any of the previous criteria that was used, with a sensitivity of 73%, specificity of 99%, and particularly a positive predictive value of 87%, and a negative predictive value of 98%. They looked at this new, what they called new early allograft dysfunction live donor liver transplant model, using the 5 days of the 3 variable after postoperative day 7, and they show that this yield an area under a curve of 0.86, which was better than the one previously showed by other authors, Althoff et al. And the study from Asia. So now changing a little bit of topic and talking about the challenges with small pore size in the living donor liver transplantation and approach to treatment. Our practice in Toronto. First of all, I thought that I would give a very brief overview of the live donor liver transplantation in our program in Toronto. As you know, we are the largest North American live donor liver transplant in the Western world. The program started in 2000, and this is the first donor who at that time underwent surgery. These are the 3 surgeons that were involved in that surgery: Dr. Gregg, Dr. Superina, and Dr. Cattrall. Dr. Cattrall is still the surgical director of our live donor transplant program and quite actively involved. Dr. Gregg has retired a few years ago. And this was the donor who at that time came forward and donated the left lobe of his liver to his, the left lobe of his liver to his daughter, who was a baby and has now graduated to the adult program 20-something years ago. This is the evolution of living donor liver transplantation in Toronto. The blue side of the graph represents the deceased donor in our program, started again in 2000. The yellow side shows the living donor liver transplantation, and as you can see, over the years our program has grown, and and as of last year, we have done 85 live donor liver transplantation in Toronto, which has been the highest number that we have achieved. And over the last few years, there has been some changes in our leadership, but as you can see here, our program has now continued to grow even despite the challenges associated with COVID. Now, looking at the small for size syndrome in the setting of living donor liver transplantation, we looked at our program a few years ago and published the result in 2016. We have looked at 510 adults, all right lobe donor liver transplant, and we found an incidence of 6.2% small for size syndrome. As you can see, majority of these patients were in fact in the group with a graft recipient body weight ratio below 0.8, and very few of those were in the group with which has received a bigger size of the graft. In terms of the approach to the diagnosis, so we perform a paracentesis on all patients, ruling out any infection, any other cause for the development of ascites. All of them have a Doppler ultrasound and a CT of their abdomen, as well as a transjugular liver biopsy. And in terms of the management, post-donation, we put all of them on octreotide infusion, and we favor generally splenectomy over any other manipulation, such as splenic artery ligation or embolization. And in the series that I mentioned, 32 of the 36 patients underwent a splenectomy, and we found similar graft and patient survival at 1, 5, and 10 years post-transplantation, and this did not seem to affect their outcome. So, on conclusion, the mechanism of early allograft dysfunction is certainly different in the setting of deceased donor and living donor liver transplantation. Early allograft dysfunction impact graft and patient survival. Predictors criteria for early allograft loss due to EAD needs adjustment, and intervention possibly in the setting intervention is a possibility in the setting of early allograft dysfunction for a live donor liver transplantation, in contrast to the deceased donor liver transplant, where we just have to wait and hope for the graft to some degree recover, otherwise facing a retransplantation. And I would like to thank you all, just a little snapshot. This is a picture that I made from my office at University Avenue. That's the view from the window of my office as of December 1st. But since we are in Canada, things can change significantly. And this is the same view just a week ago, where we had a significant snowstorm in Toronto, and had overnight about 70 centimeters of snow. Thank you again all for listening, and I'm happy to answer any of the questions.
Thank you very much, Dr. Anazia, for this excellent presentation. And just a couple of questions. First one, do you think is there any correlation between the preoperative severity of end-stage liver disease, like patient with advanced mild disease, and the possibility of occurrence of early graft dysfunctions? And the other questions, also the criteria of the donors could be related for early graft dysfunctions in patients with living donor liver transplantation?
Good morning, everyone. Can you all hear me?
Yes.
Perfect. Your first question pertained to the severity of the disease and the risk of early allograft dysfunction. I assume we are asking in the setting of deceased donor liver transplantation. And you know, the risk of developing early allograft dysfunction in this setting, in the setting of deceased donation, is all related to reperfusion injury and mainly related to the donor risk factor as well as cold ischemic time. And warm ischemic time if we are talking about the DCD graft. And also in our analysis of the data in our paper that was just published a year ago, we did not find the MELD score being a risk factor, but other parameters such as age, BMI, and HCV positivity. For the living donor liver transplantation, again, the question, sorry, for that one, the question was again the donor, the factor. No, because once again, for living donation, the donors are supposed to be all very healthy and have excellent quality of graft, and this should not be a risk for development of early allograft or small for size.
There's a question from the floor. Fadal.
Thank you. Actually, I'm a surgeon in the team of LDLT. I'm asking you about there's some trend of normal perfusion instead of cold perfusion. And because there are some unknown factors about ischemic reperfusion injury, and every year, we are discovering new factors like reactive oxygen species and so on. What do you think about normal perfusion at present state instead of cold perfusion? Thank you.
So you are asking about the normal perfusion reducing the risk of early allograft dysfunction. And yes. The answer is yes. I think that is, there are certainly this strategy seems to be extremely helpful and promising. Particularly, but mainly in the setting, I would say again, the DCD allograft, where the risk factor is quite higher, and perfusing those organs on a normal setting, normal thermic setting, trying to reduce and avoid as much as possible the cold ischemic time, would allow, as you mentioned, to reduce some of those bad parameters that are known to be associated with the severity of ischemia or perfusion injury, such as reactive oxygen species, and therefore improve the quality of the graft and should theoretically avoid the risk of early allograft dysfunction.
Thank you very much.
Thank you very much, Professor Nazia, for this elegant lecture. And we're going to move now for the next lecture. It's going to be said by Dr. Mohammed Saeed Abdelaziz, Professor of Hepatology and Gastroenterology and Liver Transplantation in Cairo University. And it's titled by the updates in immunosuppressive drugs in liver transplantation. Professor Mohammed.
Thank you, Dr. Mohammed. So this is my agenda. So there are many milestones in the development of liver transplantation, starting from 1967 with the first extended survival liver transplantation, and the introduction of cyclosporin as one of the important immunosuppression in 1979, and the first NIH consensus conference established liver transplantation as an acceptable treatment for ASLD in 1983, and the first successful living donor liver transplantation in 1990, introduction of tacrolimus in 1994, and the introduction of sirolimus as the first mTOR inhibitor in the liver transplantation. For the annual report of the European Liver Transplant Registry for data from for the 50 years evolution of liver transplantation, they reported more than 146,000 cases have been transplanted in Europe, and behind this success improved survival, short-term and long-term survival. What behind this success is standardization of the donor organ procurement and the implementation of the operation, recognition and application of multidisciplinary team approach, improved immunosuppression, enhanced peer-operative care, and the liver transplantation became the definitive treatment of virtually all types of ASLD with a remarkable accomplishment. And among these success is the improved immunosuppression. And despite the considerable progress in solid organ transplantation leading to increased patient and graft survival, complications associated with maintenance immunosuppression therapy required to prevent rejection remain a major issue, with many complications due to the use of calcineurin inhibitors like renal dysfunction, metabolic disorders, neurotoxicity, and de novo malignancy. And the causes of mortality early post-transplant differs from the causes with long-term transplant. The causes of early mortality is due to infection, primary non-functional graft, or dysfunctions or technical complications. However, the causes of mortality after the first year related to tumor recurrence, tumor de novo, non-tumor recurrence, infections, and to less extent rejection. And surprising enough, in this article, there are no gains in long-term survival after liver transplantation over the past 3 decades. And they retrospectively identified all the adult liver transplant recipients between the period of 1987 and 2016 from the UNOS database. And they analyzed the long-term outcomes of more than 110,000 recipients. And they divided or classified the errors arbitrarily used roughly 4 years period to create time period cohorts. They found that there is significant improvement in the short-term survival, 1 year survival between different errors, while there is no much increase in the long-term survival when they compared between different errors. And the cause of death for 1 year survivors, they found that across the time period, the only cause of death that significantly increased was malignancy from 15% in 1987 to 27% in 2016. In contrast, this is due to allograft failure, infection significantly decreased. And they stated that in contrast to short-term survival, there have been no appreciable gains in the long-term survival following liver transplantation, and long-term sequelae of immunosuppression are the most common causes of death, including malignancy and infection. But there is a room for improvement, and this study suggests that most important starting point is better long-term immunosuppression management. And the evolution of immunosuppressive drugs, this is the time frame for the evolutions of the immunosuppression. And there is a significant increase in the use of tacrolimus. It became the backbone of immunosuppression in the liver transplantation in the recent decades with mycophenolic acid. And currently, tacrolimus has mostly replaced cyclosporin as the primary choice for post-transplant rejection prophylaxis. And it's characterized, as you know, by a narrow therapeutic index and a large interpatient variability. And this interpatient variability is an emerging risk factor for solid organ transplantation, which may lead to periods of underexposure and overexposure, thus causing immune complications or drug-related toxicity. As a high interpatient variability was previously associated with poorer graft survival, occurrence of de novo donor-specific antibodies, acute rejections, or calcineurin inhibitors associated with kidney histological lesions. And among the many risk factors for a graft rejection episodes, the interpatient variability more than 35% is associated with poor outcome in univariate and multivariate analysis. Still, it is risk factors, it's important risk factors for development of de novo donor-specific antibodies. In another debate about the interpatient variabilities is article which published in 2019 in the Transplantation. They have two endpoints. The primary endpoint is compromised graft outcome due to immunological causes, was it chronic rejections or acute late rejection. And the secondary endpoint is the loss of renal functions after 6 months and the CMV viremia. And they didn't find any correlation between the interpatient variability and the tacrolimus levels and the composite endpoint, with no difference whether the interpatient variability less than 28% or above 28%. So they concluded that in this study, including 326 liver recipients, a high interpatient variability and tacrolimus exposure beyond 6 months post-transplantation was not associated with graft failure due to immunological causes, and they suggest that the liver transplant may be less susceptible to tacrolimus fluctuations than reported in the setting of kidney transplantation. FDA approved the tacrolimus extended release capsules for kidney transplantation with mycophenolic acid in 2013. And the European Liver Transplant Registry published this article in 2019, as they reported the analysis of up to 8 years data collecting from 2008 and 2016 as an extension study with the aim of comparing long-term liver transplant outcome with prolonged release versus immediate release tacrolimus. They also studied the outcome of converting patients from one formulation to another. They included 1,700 cases with prolonged release tacrolimus versus immediate release tacrolimus in about 11,000 cases, and they did propensity scoring matching in 1,000 cases of prolonged release versus 2,000 cases. And they found that there is significant improvement in the graft and the patient survival in patients with prolonged release tacrolimus versus immediate release tacrolimus. And the same found when they did propensity scoring matching patients, there is significant improvement in the graft and the patient survival when they compared between patient received the prolonged release tacrolimus and the immediate release tacrolimus. And among several factors associated with reduced graft and the patient survival, like recipient with HCV, recipient age more than 55 years, status 1 or 2, serum creatinine more than 2, the immediate release tacrolimus immunotherapy is associated with a hazard risk ratio about 1.49 in this study, whether in the grafted survival or the patient survival. And the potential mechanism underlying the improvement in long-term graft and patient survival was prolonged release versus immediate release tacrolimus-based immunosuppression, based on the reduction in the variability of tacrolimus exposure, because it offers a similar regimen with a single morning dose, which can improve medication adherence. Given that high intrapatient variability in tacrolimus exposure and medication non-adherence have been associated with poor transplant outcome, and the prolonged release tacrolimus may improve long-term graft and patient survival compared with immediate release formulation. In another evaluation of the immunosuppression, the mycophenolic acid, with the major advantage is using the mycophenolic is their lack of renal toxicity. In patients with pre-existing renal disease, they have been used in conjunction with low-dose calcineurin inhibitors as a part of renal sparing protocol. In these publications in the Journal of Hepatology in 2011, they stated that there is significant acute renal dysfunction to occur in 40% of liver transplant recipients with post-operative period, and it is a major predictor of late chronic renal insufficiency. Acute renal failure requiring renal replacement therapy occurs in about 15% of liver transplant recipients. And they suggested an algorithm for management for patients with renal dysfunction pre-liver transplant or early post-liver transplant. They consider induction therapy with basiliximab or ATG with MMF and delayed or reduced calcineurin inhibitors with expected improvement in renal function at 1 and 6 months. And in patient at risk of renal dysfunctions with pre-liver transplant, like a patient with refractory ascites or post-liver transplant, they suggested that consider reduction in calcium doses with MMF or anti-CD25 based induction therapy with expected improvement in renal function without increasing rejection is to be tested in specific trials. And by 5 years post-liver transplantation, a significant multifactorial chronic alteration in renal functions in up to 40–50% of liver transplant recipients with severe renal function is observed in 5 to 15% of the cases, which is had a bad impact on long-term survival. And in these cases, mycophenolic acid with minimization of calcineurin inhibitors associated with improvement, stabilization of renal function. And another evolution of immunosuppression is the everolimus. And the International Liver Transplantation had a recommendation for the use of everolimus in liver transplantation published in 2017. And as you consider renal sparing immunosuppressive strategies for liver transplant recipient includes the following option: a triple or quadruple regimen with the use of induction agent in association with antimetabolite, delayed introduction of calcineurin inhibitors with or without steroids, and everolimus facilitated calcineurin inhibitors reduction starting 30 days after transplantation. However, early introduction of everolimus before 10th day could be used. And the delaying renal sparing intervention strategies until glomerular filtration rate less than 60 is associated with only minor improvement in renal function. So the intervention is needed to modify the CNI before the deterioration of kidney functions. And CNI withdrawal, complete withdrawal, is associated with 10 to 20% risk of acute rejection of the liver graft depending on the time of discontinuation after liver transplantation. So it's recommend minimization rather than complete withdrawal. Due to different pharmacokinetic interaction, tacrolimus should not be reduced before everolimus in the target blood range more than 3, whereas cyclosporin should be reduced once administered the everolimus. The other evolution is the anti-interleukin-2 receptor blocker. The immunosuppressive antibodies with our what's called induction therapy. It's anti-interleukin-2 receptor antibodies are approved for clinical use are the basiliximab and daliximab. Both antibodies are specific for alpha chain of the interleukin-2 receptors, CD25, which is the only expressed on activated T cells. Is given IV, half-life 7 days, and it's well tolerated with only GIT disorders. And in very recent review about the renal functions after liver transplantation, real-world experience with basiliximab induction and delayed reduced dose, this paper is published in digestive disease and digestive liver disease. They reported the effect on kidney functions, rejection episode, and survival rates of real-world experience with basiliximab induction and delayed onset reduced attack given routinely to all patients undergoing liver transplantation, regardless of pre-transplant kidney functions. And they compared the protocol with the previous one with immediate standard dose of TAC and adjusted for multiple confounders. They have 627 cases classified into conventional treatment group as 200 cases, and the revised treatment group who received induction therapy with basiliximab in 343 cases. And they showed that there is a significant improvement in GFR at 3 months post-transplantation in the induction group versus the conventional therapy. And this improvement is maintained after 12 months after transplantation, with more improvement in the GFR with the use of induction therapy. They concluded that basiliximab induction was delayed reduced dose of tacrolimus associated with less kidney injury when compared to standard dose tacrolimus without increased risk of rejection, graft loss, or death. What are the current concepts of immunosuppression? They depend on the individualization or tolerating of immune suppression. Liver transplant recipients are a heterogeneous group of individuals, different predisposing factors for the development of acute cellular rejection, different comorbidities, which means that a single optimal and universally applicable immunosuppressive protocol is not applicable. And there are several strategies for use of immunosuppression in liver transplant. We have a patient who are standard patients with low risk, patients with MELD score less than 25, no autoimmune liver disease, no HCC or history of renal dysfunctions. And we have a critically ill patients with high MELD sodium, renal dysfunction, portal vein thrombosis, sarcopenic and frailty, metabolic syndrome, high surgical risk. And there are many specific etiologies we will deal with. And the Italian group recently published a consensus recommendations in the real life practice as regards the immunosuppressive regimens and living in the liver transplantation. And they recommend the use of tacrolimus with MMF with minimization of the level of tacrolimus to 3 to 5 nanogram per milliliter in the first 3 months post liver transplantation and in the standard patient, or the use of TAC everolimus, also minimization of the TAC in the first 3 months. But if we have a patient with an intraoperative problems like ischemia, hypotension, sluggish urine output, or any surgical complication which may suggest post-operative renal impairment, so the induction therapy is used in these patients. However, still the cancerine-free regimen could be used with very cautious maneuvers. However, the tacrolimus monotherapy is not recommended. After 3 months, still the same regimen, TAC MMF or TAC everolimus, it can be used, and cancerine-free regimen could be used with cautions. In critically ill patients, the induction therapy is recommended followed by cancer-free regimen, or the TAC MMF or TAC everolimus could be used. And after 3 months, the same is TAC monotherapy is not recommended. TAC MMF or TAC everolimus can be used. So induction therapy with mirikizumab is recommended in critical ill patient to delay the introduction of CNI to 3 to 5 days post-transplantation. CNI should be initiated at lower doses as compared to standard patients. CNI reduction, the available options include mycophenolic acid derivatives and everolimus. CNI discontinuation can be considered to patients with signs of CNI-induced neuronephrotoxicity. Everolimus is particularly indicated in patients at risk of renal dysfunctions or with renal dysfunction confirmed by estimated GFR. In other etiologies like patients with HCC, as you know, immunosuppression increases the risk of cancer in transplanted recipient either in the form of de novo cancer or from recurrence. And the immunosuppression after transplant for HCC can influence oncological survival and HCC recurrence. And there is significant correlation between the level of tacrolimus early period post-transplant in the first months and the higher recurrence rate for hepatocellular carcinoma, as well as the cyclosporin level. And when they compare the levels above 9 or 10 in the first months with the reduced CNI exposures, there was a significant increase in the HCC recurrence over the 3 and the 5 years post-transplantation. And in the recent publications, they confirmed the findings that the first month is critical in the recurrence of HCC post-transplantation. If we used a high dose of tacrolimus, a high level of tacrolimus beyond 8.4 nanogram, is associated with significant increase in HCC recurrence post-liver transplantation. So the cutoff for 8.4 should be considered as a high risk level for HCC recurrence in the first months. So increased risk of HCC recurrence with early exposure to high level of CNI, the first month is critical, and the trough level beyond 10 or maybe less 8.4 is associated with the risk of recurrence of HCC by increasing the risk by 3 times. So the pro-oncogenic effect of CNI is established, and there is some anti-oncogenic effect for the mTOR inhibitors and even the mycophenolate. So the use of mammalian target of ribomycin inhibitors are associated with lower rates of hepatocellular carcinoma. This systemic review was published in 2014. And they found that there is a significant improvement in the patient and graft survival and in decrease in the HCC recurrence with the patient received the mTORs when they compared with CNI. And there is significant benefit of mTOR inhibitors were only observed in patients within Milan criteria already with low risk patients. And moreover, HCC recurrence-free and overall survival benefit of M2 inhibitors were apparent for up to only 3 to 5 years, but it's not sustained beyond that. In more recent meta-analysis published in Elementary Pharmacology and Therapeutics, they compared the CNI-based immunosuppression with the M2s in the first and 3 years post-transplantation. And they found that without compromising rates of acute rejection or hepatic artery thrombosis, M2 inhibitors may be a promising immunosuppressive option in HCC transplant patient. Also, there is not current evidence for a sustained benefit longer time. So if we have a patient with HCC, the recommended regimen is tacrolimus in the first 3 months, or CNI-free regimen. If we have a high-risk patient in native histology or there is a relapse, CNI-free regimen is considered. And after 3 months, the CNI of the tacrolimus is used, and if there is a relapse or recurrence, the CNI-free regimen is recommended. De novo malignancy post-liver transplantation. If we have a patient with de novo malignancy, we have CNI-free regimen is recommended. However, the tacrolimus could be used with cautions. What about the new indication for liver transplantation, what's called Transplant Oncology, which is a new concept encompassing multiple disciplines of transplantation medicine and oncology, designed to push the envelope of treatment and research of hepatobiliary cancers. If we have a patient with HCC and a patient with cholangiocarcinoma and mixed hepatocellular carcinoma, or patient with colorectal and neuroendocrine liver metastasis and hepatoblastoma, what are the regimens can be used in these patients? The recommended regimen is CNI-free regimen, or we can use the tacrolimus but with cautions. Also, the other etiologies like autoimmune liver disease, we use the tacrolimus with steroids. We have a patient with combined kidney and liver transplant, we use a standard protocol. We have a patient with polycystic liver disease, we use the critical patient protocol. We have a patient with acute rejection of liver transplantation. I will refer to the recommendation with the International Liver Transplantation Society, which is considered treatment of T-cell mediated rejection should be determined by degree of liver injury and histological activity. Mild T-cell mediated rejection should be treated by increase in CNI and may not require steroid pulse therapy. Moderate and moderate severe T-cell mediated rejection should be treated by an increase in CNI with pulse intravenous steroid therapy followed by slow oral steroid tapering. When selected patients with severe T-cell mediated rejection associated with significant graft injury and cholestasis, antibody depleting therapy can be considered as a first-line therapy. Steroid-resistant T-cell mediated rejection should be treated with antibody depleting therapy. What about the future perspectives? Our future perspectives are the novel immunotherapeutic approach, immune monitoring strategies, and transplantation tolerance. The new concept of immunological pathways depend on the presence of effector cells, which promote the inflammation and allograft damage, and the presence of regulatory cells, which promote tolerance, and there are many determinants of the liver immunogenicity. This is a conventional specific immunosuppression described before. There are the novel immunotherapeutic approach depend on the cell-based approach, like adaptive transfer of ex vivo expanded immune regulatory cells, stem cell therapy, promoting endogenous immune regulatory cell functions and or expansion, target immunotherapies like inhibiting inflammatory cytokines, inhibiting T and B cell signaling, inhibiting B cell and T cell depletion, or approaches to reduce liver allograft immunogenicity by machine perfusion, target immunotherapies, or cell-based immunotherapies. Immune monitoring strategies trying to stratify recipients according to their immunological risk pre and post-transplant, identifying rejection and graft damage before it becomes clinically apparent, detect over immunosuppression to identify tolerant recipients. What about the immunological self-tolerance, which is the ability of healthy immune system to produce a protective immune response to pathogens and foreign antigens while maintaining tolerance to its own tissues? Transplant tolerance refers to accepting organs without the need for long-term immunosuppression and maintaining protective immunity. And tolerance is usually classified as complete immune tolerance, operational tolerance, which is defined as long-term functional graft survival in a patient not requiring maintenance immunosuppression, and the probe tolerance, which is defined as a condition with a low non-toxic dose of immunosuppression. Over nearly 3 decades, many liver transplant centers have conducted clinical trials for immunosuppression withdrawal, about only 20% of patients achieving complete immunosuppressive withdrawal. And they depend on the balance between the graft inflammation promoted by the effector cells. If we have a much increase in the effector cells, so there is increase in the risk of graft rejection. We have increase in the regulatory cells, so we have a greater graft tolerance. And in these publications published in Journal of Hepatology 2015, they reviewed all the new mechanism of tolerance, like development of target immunosuppressive regimens like small molecules, antibodies, or fusion proteins, but they have several challenges like relatively small patient population, increased cost of clinical trials, and the lack of clinically relevant short-term endpoints, development of biomarkers. Still, there is a large prospective studies are needed and confirmatory for these biomarkers to predict the immune response, and identification of spontaneous operational tolerance. There is an independent large cohort of patients is required, and only selected recipient long time after transplant likely to benefit. Induction of tolerance, like adaptive transfer of ex vivo expanded regulatory cells, is very high cost and requires infrastructure. There are many mechanisms and many modalities, strategies for induction of tolerance, but all are still experimental. So my closing remarks is to truly optimize long-term outcomes, individualized immunosuppression in the next decade needs to be coupled with continuous work to improve the post-transplant comorbidity management and reduce medication non-adherence. The transplant community needs to continue to find new ways to simplify immunosuppression regimens, improve follow-up monitoring, and reduce the financial burden, and extending the scope of immunosuppression to immune tolerance, leading to a promising strategy for overcoming the deleterious effects of the immunosuppressive medications. Thank you.
Thank you, Dr. Mohammed, for this elegant lecture. It's very nice and very informative and conclusive. Actually, I've got no questions for you. Thank you.
Thank you.
And now we're going to close this session, waiting for the next session that's going to be in nutrition at 2 o'clock.
Will be at 2 o'clock.
Just a 15-minute break. Thank you.
إيه،
لمن هنا مرة أخرى لفائدة منتخب المراوي لازم من حسم المباراة بهدف ثالث، لأن 2-1 نتيجة غير مطمئنة. 2-1 كل شيء يبقى ممكن، وبالتالي الواقعية المطلوبة معناه هدف ثالث يحسم الأمور. تمشي كرة بوفال لمن يا بوفال، والكرة تخرج إلى الجانبية في هذه اللحظات. إذا تماس لفائدة منتخب المراوي. هل سيخرج للهجوم؟ لو خرج مشاهدينا الكرام، لو خرج المراوي للهجوم أقول لكم يعني الشوارع ستكون حاضرة، وبالتالي هذه فرصة للاعبين
4 4 2 1 7 3 8 7 3 8. كنا عاوزين نعرف نغير الشاشة كلها، نعرف نخلي الشاشة كاملة ولا هيبقى صعب؟